Tuberculosis is a devastating illness caused when individuals fall victim to the bacterium called Mycobacterium tuberculosis. It is categorized by painful symptoms that affect the lungs and attack any part of the body, including the kidneys, spine, or brain. It is also spread through one of the most dangerous methods, inhalation. When breathed in, tuberculosis settles in the lungs and slowly robs individuals of their ability to breathe properly, and may even inhibit individuals from being able to support their families and perform daily functions. Though curable and preventable, tuberculosis impairs the functioning of millions of people every year. In the year of 2014, 9.6 million people were infected with tuberculosis all around the world. Our initiative is not addressing a simple fix for mild illness. We are facing the reality of implementing preventative measures that could have a tremendous impact in the lives of the 171,452 people who tested positively for tuberculosis in the state of Uttar Pradesh, India. We are facing a greater issue at hand. Individuals who have compromised immune systems, HIV, or other autoimmune diseases are at a greater risk for contracting tuberculosis. These individuals are also typically on the lower end of the economic spectrum. They often do not have access to the resources or funds available for tuberculosis prevention. When there are thousands and thousands of individuals who contract a very invasive illness that is completely preventable, then we must ask ourselves the following question: where can we intervene? This involves more than social or economic issues. It's more than disease prevention. It's about extending a helping hand and making a difference in the world where it is completely possible. Though tuberculosis may not be as detrimental as other invasive illnesses in the world, there are various measures that we can take in order to make a contribution to this effort. As a general reference, we'll begin by addressing the question, what does tuberculosis look like and feel like? And three of the main categories that health practitioners generally look at when diagnosing tuberculosis are central symptoms, symptoms of the lung and of the skin. Central symptoms usually include a generalized tiredness or weakness as demonstrated in this photo, also weight loss, fever, and loss of appetite. Some of the symptoms in the lungs are coughing, a pleurisy, which is a sharp pain felt in the lung when breathing deeply or coughing, and coughing up mucus or material from the lungs, as well as blood. Let's focus in on India and tuberculosis, specifically in the state of Uttar Pradesh, India.
20 years ago, it was widely believed that India was successfully on its way to controlling its alarming tuberculosis epidemic. However, each year, India has 2.2 million new cases, more than 300,000 deaths, and approximately 3 million people infected with tuberculosis. These statistics make this public health problem the world's largest tuberculosis epidemic. Despite widespread knowledge of this, the government over the last few decades did little to change these statistics. Unfortunately, the government's inability to view tuberculosis in a broader public health framework and its failure to effectively engage in the private sector as a partner in controlling tuberculosis continues to cost India thousands of lives. A decade of neglect has now resulted in an epidemic of multi-drug resistant tuberculosis with close to 100,000 cases. Considering that 17% of tuberculosis patients eventually become resistant to basic anti-tuberculosis treatment, the risk of multi-drug resistant tuberculosis is now a big concern for the state. It is the most populated of the Republic of India and is the most populated country subdivision in the world. It is the fourth largest state according to its area size. Its population is really dense, with 828 people per square kilometer, which makes this particular area a big concern for tuberculosis. Every second Indian undergoing treatment for tuberculosis comes from Uttar Pradesh and has the largest number of infected people in India with tuberculosis. In 2014, the epidemic was so bad in Uttar Pradesh that the state was under an unofficial quarantine.
Now we'll take a look at the first part of our initiative.
We feel that an environmental approach is the best way to address the continual spreading of tuberculosis, or TB, in this region. Our first approach is to distribute face masks to the whole population in the region. Face masks will be the first line of defense, as those who have active TB cough, sneeze, or breathe out the contaminated droplets. The face mask will capture and retain it, therefore eliminating a portal of exit. This has been proven by Dr. Ashwin Daramahi, an associate physician at Harvard Medical School Brigham and Women's Hospital, when he said, "We found that when infectious patients with multi-drug resistant tuberculosis wore face masks while they were hospitalized, the face mask helped decrease the transmission of tuberculosis by 50%, compared to when patients did not wear face masks. Simply put, face masks were able to cut tuberculosis transmission in half." With Uttar Pradesh's population of over 21 million people, we found that it was increasingly difficult to hand out face masks to each individual. Therefore, we decided to target hospitals and those who would most likely come into contact with tuberculosis patients. We would have signs around the area as well promoting face mask use and explaining the reasons why they are important to wear in public settings. Having many hands and volunteers to help reach the most heavily infected populace will increase the likelihood, like Dr. Mahaki said, for cutting transmission of the disease in half. Prevention, ultimately, is the first step in overcoming a disease that is so virulent, such as tuberculosis.
We'll address some of the stipulations to this first initiative.
We wanted to implement face masks to the individuals in Uttar Pradesh. However, it is extremely hard to implement face masks to every individual. So instead, we decided we would still use face masks, but we would provide them in hospitals and clinics to those that have tuberculosis or those that have the symptoms of tuberculosis.
Now we'll focus in on the second initiative.
The second step is increasing ventilation in big populated buildings, such as airports, places of worship, hospitals, and schools. As a result of this increase in ventilation, our desire is to decrease the likelihood that contaminated air will stay stagnant long enough for a new host to contract the bacteria by breathing in the infected air. Along these same lines, we will also focus on public education and teaching about TB so that people can understand how it is spread and how to protect themselves. Once people are educated about the severity of the disease and how easily it is contracted and spread, they will be armed with the information needed to keep themselves and their families safe.
Now we will address our third and final initiative to combat tuberculosis in Uttar Pradesh, India.
The third environmental factor we will address is the DOTS distribution method. This is because it has been proven to work before in treating TB. DOTS stands for Directly Observed Treatment Short Course. Studies show that 86 to 90% of patients receiving DOT complete therapy compared to 61% of those on self-administered therapy. This essentially means that we will have health providers that are providing the medication treatment watch the patient physically swallow their medication to make sure that they take their full treatment. Many people feel as though they are feeling better, so they stop taking the medication and don't finish their full treatment course. But then the tuberculosis becomes drug resistant. This causes a really big problem in our overall goal to eradicate tuberculosis. DOTS has been proven to effectively treat and eradicate disease specifically in India before. In 2010, the DOTS Plus guidelines, or otherwise known as Programmatic Management of Drug-Resistant TB, came into place. This separated patients into 4 separate categories. Category 1 was for newly infected patients. Category 2 was for previously treated patients. Category 3 was patients needing MDR-TB, or multi-drug resistant. And Category 4 was for patients requiring XDR, or extra drug-resistant tuberculosis. The initial phase for new patients' treatment consisted of 2 months of drugs isoniazid, rifamycin, pyrazinamide, and ethambutol. The continuation phase should consist of all these same drugs except pyrazinamide for an additional 4 months. In certain cases, this may be extended to 6 months. So as you can see, this treatment takes a very long time to work. So this is why the DOTS system is so vitally important, so that patients do not decide to stop in the middle of being treated as a result and become drug resistant.
We will now address some of the stipulations with this third and final initiative.
One of the main barriers that we encountered was that we originally planned on using UV lights in buildings all around Uttar Pradesh to break down the bacteria called Mycobacterium tuberculosis, which is in the air. Even though this has proven very effective, as it destroys the bacteria's DNA, which can inactivate it and increase the quality of indoor air, we ran into problems implementing this into numerous buildings. Therefore, we chose to not use UV lights, and instead we decided to implement the DOTS distribution. The reason for this is because we did not have any contacts currently living in Uttar Pradesh, and none of us really had any personal experience with treating tuberculosis. We also didn't have any financial support to fund or create these UV lights. The transportation and installation were also a problem for us as they required more financing and support, which again were not available to us.
Let us explain how these initiatives will differ if implemented in different parts of the world.
Hi, my name is Gabrielle Phillips. From our research, we feel that our program will work well for those in our target population, but this program would need slight changes and adaptations if used in other countries. If our program were implemented in other countries such as Africa or Haiti, it would be difficult to implement more rules on building regulations to help ventilation and incorporate UV lights when current building regulations are not being followed. For our program to be implemented, we would need to take this into consideration and focus our efforts more on the DOTS program mentioned above.
Now, we may ask the question, what would this program look like if it were implemented in the United States? Gabby will elaborate.
If our program were implemented in states within the United States, we would be able to use the UV lights and the ventilations and the DOTS program. These areas have more access to tools needed to make these efforts work and would be easily implemented. As with any program, it is important to take into consideration the people you are serving. Every program should be adjusted to suit the target population and their special needs.
Finally, we will discuss how our three-initiative intervention will make a difference in tuberculosis in the state of Uttar Pradesh, India.
Our program will bring awareness and offer viable, efficient, and effective measures to combat tuberculosis in Uttar Pradesh, India. Our program will be successful because we are focusing our efforts on personal as well as environmental factors. We will educate individuals on the use of face masks as well as other prevention tips for tuberculosis. We will enhance the environmental factors by increasing ventilation in public buildings that have a heavy traffic flow. We will help decrease the spread of the disease by eliminating the places that it spreads the most often. We will incorporate the DOTS program to further aid patients to take their medication and decrease the rates of antibiotic-resistant tuberculosis. Through these efforts, we will reduce the rate of tuberculosis in Uttar Pradesh, India, and provide a healthy environment where TB cannot spread, and help those who currently do have TB.
This brings our presentation to a close. Through the statistics, detailed analyses of various initiatives, and goals to implement these proposals, we hope to have brought one main message across the board. No matter the circumstance, and no matter the obstacles, there is always something to be done to make the world a better place. According to the World Health Organization, in 2009, there were over 10,000 causes of maternal, communicable, perinatal, and nutritional conditions in India alone. These numbers have surely changed over the years, but they bring us back to the same message that is this: where there is a need, there are also individuals who can make a change. In the 7.4 billion people on this planet, even one can make a difference. Let us begin to make that change today through small and simple steps. This brings us to the conclusion of our presentation on tuberculosis in India. Thank you for listening.